this morning, I'm going to talk about immediate implant placement and how will it affect the dynamics of the gingiva around anterior single implant. So to begin with, we're going to look at two patients. Both of these patients had an implant placed, and you can see there is facial gingival recession. The question for me to you is, which one of these two patients, or either one of these, are they placed in an immediate or delayed fashion? Now, let me show you what happens before you make the decision there. Let me have you take a look closely at how the gingiva is, how the papillae is, the position of the papillae. And for each one of these patients, they were placed in an immediate. The one on the left was immediate. The one on the right was placed in a delayed fashion. My point is this. Interestingly enough, throughout the years, I noticed when I put implants in a delayed fashion, there's still, to a certain degree, there's facial recession too. So they do happen. And this is the outline of what I'm about to talk to you about today. Begin with, we're going to talk about immediate versus delay. Now, when I reflect the gingiva on both of these patients, you'll see that the buccal plate is completely gone. If I did not tell you, you probably would have guessed that both of them would be placed in an immediate fashion there. So now, let's begin with looking at how did they look beforehand. This is how those patients first look before the surgery and everything. And I'm going to focus on immediate first, then we're going to look at delay and see what the literature has to say comparing these two procedures. The first patient, what the surgeon did is she put an implant right after the extraction of the tooth, put a provisional in there, immediate tooth replacement. Everything looks really good for the first 5 months. Then at month number 6, unfortunately, this happened. If you notice the papillae, it had been well protected within a certain degree, but there's facial recession. Now, the way I actually treated this patient is to try to resolve the problem is I removed the provisionals, did tissue graft and bone graft, submerged the implant, and then 2 months later, we uncovered the implant, and the restorative dentist put a restoration in. Almost like a delayed 2-stage procedure. So you'll notice that the facial tissue had been solved to a great degree. However, we introduced another problem, the papillae issue there. So my point is this, every time when we do immediate, because we use the provisionals to protect the papillae, the chance of papillae loss is actually very small. Unfortunately, there is a tendency of facial tissue problem. On the other hand, when we do delayed 2-stage procedure, because of the lack of protection of the papillae immediately following tooth removal, there's a tendency of losing the papillae. But if there's anything, we can control how that facial tissue looks like. Now, do we have any scientific data regarding immediate tooth replacement? This is actually one of the very first publications looking at such a matter in a prospective manner. What the authors here look at is 35 Nobel Biocare implants over time. They find out that 1 year prospectively, there are no failures. When you look at the tissue changes, both facially and interproximally, you'll notice that, based on this article, less than 0.5 millimeters of recession. So when people interpret this procedure with this information, this is probably a great procedure, right? But the question now remains is, what happens when we follow the same group of patients over time? This information actually already been accepted with revision with the same journal. And what the authors did follow the same group of patients, you'll notice that now up to 82 months, all those implants are still working fine. But if among everything else, one critical variable is that facial tissue, minus 1.1 compared to minus 0.5 millimeters. And mind you, you'll notice that some of the patients in these studies, after 4 years minimally, you have no facial tissue loss. Some, unfortunately, have up to 3 millimeters of facial tissue loss. If you pay attention to the interproximal papillae, actually they have been maintained very well over time. Now, mind you, when you look at the article that was published in 2003, you know that every time when we do studies, from the published date, it probably would have started at least 4 to 5 years ago. And that is in 1998 information. These are some of the points that we do not understand. But now we have a much better understanding. For example, the thickness of the tissue, how will it impact implant? At that time, people always say if there's a gap, If it's less than 1.5 millimeters, you always leave it alone. If it's greater than that, you always graft. How about the dimension of the implants? People always think big is better, but is it big always better? Last but not least, in those days, gold alloy abutments is basically the gold standard. Things have changed. Let's see, by changing things, will that affect of the dynamics of this type of procedures on the tissue aesthetics? Now, this is patient number 2. Remember the delay procedure: extraction, socket preservation, approximately 4 months later, implant placement. And you can see over time, unfortunately, there's a certain degree of facial recession too. And you've already know that when we raise the flap, basically the buccal plate is completely gone. Now, I'm going to take you back to basically 1996 when the surgeon did the surgery in the operating room. You can see that the ridge is nice and big, and to a great degree, the buccal plate is there. So what happened? Why, when we do immediate and delay, sometimes not all the time, there's still a propensity of slight facial tissue recession? So what I did is this. With this question mark, I asked myself 5 questions, comparing immediate versus delay. The next thing I did is I went into the literature and did a critical literature review, basically looking at all the literature that mentioned about each one of these topics, and did a little comparison. This is what I find out. Facial tissue loss, comparing immediate versus delay. You'll see the bracket denotes that how many articles there are that mention about this issue here. If you notice, it's quite similar. Delay also can have facial tissue recession. How about implant failures? Interestingly enough, almost the same, and bone loss, likewise, almost the same. Now, based on the literature, unfortunately, there's not a lot of comparison between immediate and delay. So what I'm going to talk about, show you, is some to be about published material here. What the authors look at here is what happens to the papillae when you have a failing tooth that is completely intact. After the extraction of the failing tooth, you go through 2 types of procedures. One is either immediate tooth replacement. One is socket preservation, subsequently implant placement, using a standardized jig and measure what happened to those papillae over time. Basically, 32 failing teeth, 16 implants in each group. Like I say, one group is immediate papillae support, the other no papillae support, using the stand to measure papillae. This is the results here. You can see that with the patients on the top, that is immediate, with the socket preservation over time. After that, put implant in with papillae sparing incision, and then subsequently the papillae, if you look critically, have been shortened. There's no black hole there, but papillae have been shortened. On the other hand, when you look at immediate tooth replacement, you'll notice that there's some facial recession, but the papillae have been well maintained. So how does these 2 procedures compare over time 1 year later? With the 16 implants in each group here, you'll notice that group 1, immediate tooth replacement, it has significantly less papillae loss when compared to delay procedures with the lack of papillae protection. And interestingly enough, the number of surgery increases significantly with the group 2 group. So going back to our list there's more tendency of greater papillae loss with the delay 2-stage procedure, and technique sensitivity-wise, obviously, immediate is much, much more demanding. I always tell my students, if someone who is really good at delay implant placements, they may not be able to manage immediate implant placements very well. But on the other hand, most of the time, for people who are really good at immediate implant placements, typically they can handle the delay type of placements pretty well. So with that in mind, let's look at some of the guidelines. What are the 2010 guidelines looking at immediate tooth replacements to guarantee or ensure optimal tissue results? Looking at this patient here, and we're going to go through this patient step by step here. Presented to my office with a failing left central incisor. Let's spend a minute talk about thickness here. How do we typically evaluate gingival thickness? Now, one often used technique is utilize a periodontal probe the sulcus, and look at, can we see a probe shining through underneath there? But in general, There are three ways. We can either look at the tissue and see is it thick or thin, or use a probe, or maybe we can do a direct measurement. Regardless, one always asks ourselves is how thick typically facial gingival tissue is. And when I look at the literature, I summarize everything that I have ever published measuring facial gingival thickness of teeth in the aesthetic zone. This is what I found out come down with. Between 0.7 to 1.5 millimeters. Now, mind you, all these are in human beings, and the tissue thickness range is really small. Then one may wonder, what is considered to be thin gingiva, or what is considered to be thick gingiva then? Well, in 2008, what the authors did here is to basically arbitrarily just draw a line right in the middle and come down to 1.1. Now, there's a reason why the authors did that, because subsequently they partake on this article that will be published in the June issue of this journal here, the International Journal of Perio and Restorative Dentistry. And what the authors look at is biotype assessment via the three methods that I just mentioned about: visual, probe, and then direct measurement. The study design is all those teeth involved are failing, require either implant or socket preservation. Prior to extraction of those teeth, the authors did, randomly evaluate the facial tissue. Is it thick or thin visually? Then use the probe, thick or thin. Then, upon immediate extraction of the teeth, utilizing a tension-free caliper to measure the facial gingiva approximately 2 millimeters above the free gingival margin. This is the results, ladies and gentlemen. Based on 48 sample size, the mean tissue thickness is 1.1 millimeters with a range between 0.6 to 1.5. Now, if you look carefully, they're similar to, this data is very similar to what the published data already established. But it is this next set of data that surprises us the most. If you look carefully, V means visual, P means probe, and M means direct measurements. You'll notice that visual does not correlate with direct probing a quarter of the time. Visual does not correlate with direct measurements 32% of the time. And probing does not correlate with direct measurements around, again, 26% of the time. So what is the key point? Surprisingly enough, is this, where every time when we evaluate gingival aesthetics, we know that by looking and using a probe, it is not reliable at all. Unfortunately, a lot of cases that we think the tissue is thick is actually thin. So the key thing is this: you either always try to do some direct tissue measurements, or maybe we should rethink and consider every case, manage the tissue as if they are thinned. Now, do we know anything about what happens when the biotype is thin? If you put an implant underneath there, how will the gingiva respond? Well, this is one article that will be published with acceptance already looking at that. What the authors is, remember the 35 Nobel Biocare implants, they look at 1 year prospectively, subsequently at 4 years. This is the data when they compare thin biotype versus thick biotype, certainly. For thin biotype, there's significantly greater amount of facial tissue recessions when compared with when the biotype was the thicker side. So one must be really, really careful on the biotype issue. How do we manage it in 2010? We must consider about subepithelial connective tissue graft, and I'm going to show you some published data on does it or does it not work in just a minute. Let's spend a minute talk about bone. Bone is vital to aesthetics around implants. And how do we evaluate the bone around the facial aspect of the filling tooth? Well, typically, I'm going to take you back to this classical article over 45 years ago by Gargillo. You all know that when they did the histology, the average dimension between the free gingival margin to the underlying bone, if the tooth is periodontally healthy and have been erupted normally, is approximately 3 millimeters. Now, mind you, this is a histological study. Can we apply this rule from a clinical standpoint? Certainly. My friend John Coyce published this article on human beings. He did bone sounding on the facial aspect of their central incisors. And by doing so, he was able to categorize his patient into 3 groups based on the distance between the gingival margin to the underlying bone. So therefore, normally he called normal crest, he defined when the distance is approximately 3 millimeters. Then he has the high and the low crest. Key point to remember is this. Nowadays, we know that in periodontal therapy, just doing tissue graft alone is not enough. The final destination of where the gingiva will be are highly determined by where the underlying bone is. And in fact, there is a cohesive relationship between gingiva to the underlying bone. Typically, that is 3 millimeters. In other words, once the dimension or the distance exceeded beyond 3 millimeters between gingiva to the bone, upon surgical and or restorative insult, we may create an unstable situation. The result may be gingival recession. So the key point is this: how far bone is normally below facial gingiva? Typically, it is 3 millimeters. So that is the bone situation. Let's go back to our patient with the failing left central incisors. Every case, before I start, I love to do a bone sounding to ascertain where the bone is. It says 3 millimeters, so therefore it is normal. In immediate implant situations, ideally we would like the bony socket to be intact. Mind you, not every case is good for immediate implant placement. So the next question is this. Let's go furthermore on the bone. If you put an implant way below the bone, subcrestally, can bone remain above the platform of an implant? Well, there have been a lot of controversies about, people talk about what happens when there's a disparity between the size of the abutment compared to the implant diameter, such as in a platform shifting scenario. Will that help to maintain bone a little bit better? Well, let me show you that the authors here compare basically 2 groups of implant. One without a platform shifting capability, the other with a platform shifting capability. I would like you to look at MBC. That stands for marginal bone change. You'll see that seems like the group with platform shifting may be able to hold the bone even closer to the implant platform. Mind you, if you look at the right column there, it says bone remain at or above the platform. What I mean is this. What the authors look at is on the day of implant placement, utilizing a standardized radiograph, looking at how many of the mesial distal sites the implants were placed at the time of surgery in which the bone is either touching at or above the platform of the implant. Then 1 year later, prospectively, again, utilizing standardized radiograph, does that piece of bone still remain at or above the platform of the implant? Interestingly enough, when we have a platform shifting capability implants, seems like we are getting closer. We're getting closer, all right? Of course, I'm not a big advocate of putting an implant too deep because we're pushing the envelope, all right? Pushing against the nature there. But the key thing is this. Can bone stay above platform of the implant? Typically is no. But with the platform shifting capability, we are indeed getting closer. So once again, for immediate tooth replacement, key point is we must have the facial bone intact. Second thing is try not to think about putting the implant platform below the bone. So with that in mind, going back to our patients, a traumatic extraction, we all know about that, to make sure that bony socket and the gingiva is intact.